Welcome. I am Marco Restrepo, Professor of Medicine at the University of Texas in San Antonio. I'm also the GREC Director, that stands for Geriatrics Research Education Clinical Center at the South Texas Veteran Healthcare System. Today, we will be speaking about the role of steroids in severe community-acquired pneumonia. I have to recognize that I am part of the clinical practice guidelines that recommend the use of corticosteroids in specific settings for community-acquired pneumonia. And as a government employee, the views expressed are my personal interpretation of the evidence and do not necessarily represent the views of the Department of Veterans Affairs or the United States government. Today, I only have one objective. By the end of this lecture, you will have a better understanding of the role of systemic corticosteroids in the setting of community-acquired pneumonia that is severe, with the exception of influenza. The community-acquired pneumonia that we're talking about today is the one that presents with lower respiratory tract symptoms, such as fever, chills, sputum production, cough, shortness of breath, dyspnea, pleuritic chest pain, and when we do the images, we confirm that there is the presence of a pulmonary infiltrate suggestive of community-acquired pneumonia that occurs within the first 48 hours of clinical presentation to the hospital or at the time of evaluation in the clinical practice. This is important as we would like to differentiate this from those patients that acquire the pneumonia during the hospital stay, such as hospital-acquired pneumonia or ventilator-associated pneumonia when they require mechanical ventilation for 48 hours. Therefore, this is a pneumonia. Severe community-acquired pneumonia is a pneumonia that occurs outside of the hospital setting that may present when they are too sick to the hospital or requiring ICU level of care. Here, there is an important differentiation between the non-severe patients with community-acquired pneumonia and those that have such a severe level of disease. So the first thing that we need to focus on is identifying which patients are likely to benefit with the intervention of systemic corticosteroids and which patients are not likely to benefit. For this, the community-acquired pneumonia ATS and IDSA guidelines from the United States of America recommend to decide whether this patient should go home with a non-severe community-acquired pneumonia or should be admitted to the hospital. And if the patient is admitted to the hospital, the decision is whether the patient will require a care under a ward service that can take care of these patients or a higher level of care in the ICU setting. To do this, there are recommendations to utilize the severity index score known as CURB-65 or the Pneumonia Severity Index score, PSI. This one, the CURB-65 and the PSI score will allow us to determine whether these patients with non-severe community-acquired pneumonia could be managed safely at home. Remember that the CURB-65 has 5 variables: confusion, BUN, respiratory rate, blood pressure, or age above 65. In contrast, the PSI score has some of the similar parameters, but have 20 variables total, and will help us to decide whether the patients have a risk classification from 1 to 5. Patients with the low risk classification could be managed in the outpatient setting safely. Same situation when the patients have a CURB-65 that have a 0 or 1 score. These patients are usually managed in the outpatient setting. When these scores were determined and originated, they were to facilitate whether these patients were not likely to require hospitalization nor readmissions to the hospital, and the patients were likely to survive even if managed in the outpatient setting. The difficulties encountered when we have to decide whether the patient needs admission to the hospital, and then where could this patient be placed based on the severity illness score. And this is when we utilize the severe community-acquired pneumonia recommended by the ATS and IDSA guidelines, dividing in 2 criteria, a major criteria or minor criteria. The major criteria stands for those patients that require vasopressors in the setting of septic shock due to community-acquired pneumonia. The second setting are those that require mechanical ventilation in the setting of respiratory failure. If you have one of these two major criteria, there is no other place in the hospital that can take care of these patients. In contrast, three or more of the minor criteria represented by the curve 65, such as confusion, uremia, the respiratory rate, and the blood pressure that is low, in addition to multilobar infiltrates, a PF ratio that is below 250, patients having leukopenia less than 4,000 cells per microliter, thrombocytopenia less than 100,000, and hypothermia, a core temperature less than 36 degrees. If these patients have severe community-acquired pneumonia with three or more of these minor criteria, you will say that these patients will most likely require a higher level of care. So this is important because in the following slides, you will understand that we will be talking about patients that are in the ICU setting or in a higher level of care, usually represent those with a severe form of community-acquired pneumonia, in contrast to those that have the non-severe form, even if they are managed in the hospital setting. This allows us to understand that no matter what scoring system we're dealing with, severe community-acquired pneumonia is a systemic disease, which means it has affected multiple organs. And let's just think for 1 second. If the patient has confusion, the pneumonia has affected the brain. If the patient has uremia, the patient has invaded the kidneys and affected the kidneys. When the patient has a circulatory dysfunction, such as requiring vasopressors or heavily resuscitation, this is what we call patient with severe community-acquired pneumonia. It's a systemic disease. Therefore, the picture looks more like a patient that has sepsis due to a disease such as community-acquired pneumonia. Why is this important? Because what I would like you to remember out of this lecture is that patients that have severe community-acquired pneumonia, in this particular observational study that require ICU admission in patients with severe community-acquired pneumonia, when the patient required vasopressors that were in septic shock, 32% of these patients died during the hospitalization. When the patient required mechanical ventilation, 30% of these patients died during mechanical ventilation. And even among those patients that receive appropriate empiric antibiotic treatment, 25% of these patients died during admission for severe community-acquired pneumonia. So what we're talking about is a disease that is killing patients, and one of these three patients may not make it out of the hospital if they have such a severe disease, even if we appropriately choose antibiotic therapy. What it means is, can we utilize something else, such as corticosteroids, to alter these poorly devastating outcomes that we're seeing in these patients? Now, when we look at the patients of community-acquired pneumonia, we need to remember that about 2/3 of those are a direct cause of death, led by two main problems: hypoxemic respiratory failure and septic shock, and other organs that are affected sequentially, such as the ones described here. What this suggests is the two major criteria that we just saw, septic shock and hypoxemic respiratory failure, will determine a death in about half of the patients that died in the setting of community-acquired pneumonia. Most of these deaths happen during the first 2 to 3 weeks of hospitalization of clinical presentation. And the majority of these deaths are a direct cause of death for these patients. Therefore, the patients are dying after they develop community-acquired pneumonia and not due to other reasons. This is why we have to consider an alternative that may alter these bad outcomes. And here we have why these patients died. And when there is an infection that affects the lungs, it starts in the blood system, it affects systemically. It shows that this inflammation is occurring. And if the host cannot cope with that level of inflammation, multiple organs are going to get damaged. And this is why we need to see if we can intervene at this level. This is why the 2019 clinical practice guidelines endorsed the Surviving Sepsis Campaign recommendations and suggested the use of corticosteroids in patients with community-acquired pneumonia in the setting of refractory septic shock, among those that were requiring vasopressors. All this data started from systematic reviews from small randomized controlled trials, as you can see on this figure, summarized in 2015, when the diamond is towards the left, showing that there was almost a 60% reduction of 30-day mortality. And you can notice that most of these boxes are towards the left in favor of corticosteroids. But the majority of these studies had a small sample size and the confidence interval across the unit, making them non-statistically significant different. However, when we combine it in the diamond shape, there is a significant benefit of systemic corticosteroids. This 2019 systematic review added more randomized controlled trials in patients with severe community-acquired pneumonia, and it has the same effect, although it is close to 40% reduction of mortality in favor of systemic corticosteroids. But it was not until 2020, when we had the devastating story of COVID-19 around the world, that described this organ dysfunction linked to inflammation that was not coped by the host. And this is when systemic corticosteroids could lower the pro-inflammatory cytokines, increase the anti-inflammatory cytokines, and manage to immunomodulate and also affect the blood vessels in response to the heavy inflammatory response that was occurring in these patients. This is why the recovery study utilizing dexamethasone in patients hospitalized with COVID-19 showed that among all the patients that participated in the study, it was a benefit of the use of corticosteroids. In this particular case, we're talking about dexamethasone. It was not protective when the patients were not receiving oxygen therapy, but among those that received oxygen therapy or require invasive mechanical ventilation has the biggest effect of protection in this randomized controlled trial that required respiratory support. Therefore, it started to become the standard of care that patients with COVID-19, according to the clinical practice guidelines, were recommended for hospitalized patients requiring high-flow nasal cannula, oxygen therapy, and non-invasive mechanical ventilation. Additionally, to those requiring invasive mechanical ventilation or ECMO. And this is why we shifted our practice and started utilizing systemic corticosteroids. And probably we did it so much to other patients that did not require oxygen therapy, that were not even admitted to the hospital, that we had an overuse of systemic corticosteroids. But in reality, they were only recommended among those that were in the hospital setting requiring higher levels of oxygen or in need of mechanical ventilation. It was not until 2023 when this study by a French group led by Dr. Dequin published in the New England Journal of Medicine the use of hydrocortisone in patients with severe community-acquired pneumonia. This study showed that the use of hydrocortisone increased the ICU discharge by day 28 compared to placebo, and reduced the 28-day mortality almost by half compared to the placebo. And among those patients that benefit the most were those that had a C-reactive protein above 15 milligrams per deciliter, as you can see in the figure on the bottom. In addition, the patients that received hydrocortisone with severe community-acquired pneumonia had lower requirement of intubation and lower requirement of vasopressors. However, they had an increased insulin requirement with no differences in hospital-acquired infections and gastrointestinal bleeding. Therefore, it is assumed that this is the stronger evidence to support in a randomized controlled trial the utilization of hydrocortisone in the setting of severe community-acquired pneumonia. However, almost at the same time, we published a double-blind, placebo-controlled, randomized controlled trial of patients with severe community-acquired pneumonia that received low-dose methylprednisolone. These patients were identified in a window between 72 and 96 hours of hospital presentation, received a prolonged duration of systemic corticosteroids with IV methylprednisolone, but the study was stopped early due to low recruitment by the time COVID-19 hit. The primary outcome for this study was 60-day all-cause mortality. And we show that there was no difference in survival, not even among those patients that require mechanical ventilation when methylprednisolone was used. Now remember, this is not hydrocortisone as the one utilized by the French group. Second, the window of initiation was much larger than the one utilized in the French group. And third, among those patients that require systemic corticosteroids, receive a longer duration of therapy with a different corticosteroid. If we consider these two studies, the DEQUIN and the MEDURI study that are the one performed at the VA hospital, there was still a benefit among all those patients that were enrolled in these randomized controlled trials in favor of systemic corticosteroids. You see that these two newer studies carry a significant weight, but all the boxes are towards the left in favor of systemic corticosteroids. And we can conclude that corticosteroids are associated with a lower mortality rate at 30 days compared to the control group, with almost 40% reduction of death. In addition, the patients had a lower risk of mechanical ventilation in the same study with a significant weight by the DEQUIN study, showing that these patients were less likely to require mechanical ventilation. All the studies on the left side in favor of systemic corticosteroids. But the rate of systemic corticosteroids in patients with severe community-acquired pneumonia showed almost a statistically significant reduction in the length of ICU stay and the length of hospital stay, suggesting that there are other outcomes linked in addition to death that may benefit with the use of systemic corticosteroids. However, if we really look at this, almost all the studies are trying to really touch the unit, but are towards the left. So we can conclude from the evidence that was from 2015, small number of studies, until 2023, with much larger studies and well-designed randomized controlled trials, in addition to the experience with COVID-19, that patients that receive systemic corticosteroids in randomized controlled trials are more likely to have a survival benefit when the patients have severe community-acquired pneumonia. This is why, by the time of publication of the severe community-acquired pneumonia guidelines, a large collaboration by 4 organizations from Europe and Latin America, we suggested that the use of systemic corticosteroids might be limited for those that had shock, that were severely ill, that has severe community-acquired pneumonia, because at the time, those were not yet included in the systematic review that I showed you published in 2023. Now, this year, we saw the publication of the REMAP-CAP. The REMAP-CAP was a study, randomized controlled trial, between hydrocortisone and the placebo group, the control group, that was stopped earlier due to futility. In this one, hydrocortisone had a higher mortality 15% versus 10% in the control group at 90 days. This study was stopped early because it was unlikely going to show a benefit, even if it was remained for the completion of all the sample size as initially suggested. Now, in this study, it was no measurement of C-reactive protein. However, we need to make a pause here. As I initially suggested you, with all the evidence so far, that patients with severe community-acquired pneumonia, even with one positive study and one negative study, now there is a suggestion that we could cause harm. And this is why this study with a 7-day course of hydrocortisone compared to no hydrocortisone, it was not able to show a beneficial effect on mortality. Almost at the same time was this subgroup analysis on the approaches trial. There was a study looking at hydrocortisone plus fluorocortisone for patients with community-acquired pneumonia. And this study showed that the survival was better with the use of hydrocortisone compared to the placebo group, particularly among those that have severe community-acquired pneumonia with septic shock. Therefore, it is suggested that among those that are very, very ill, requiring vasopressors in septic shock, the utilization of a combination of hydrocortisone plus fluorocortisone may benefit the survival. And about 3 weeks ago, this study, a pragmatic trial of glucocorticoids, was published from Kenya, the SONIA trial. This is a little bit different than those that I just showed you, because this included patients that were not in the ICU setting in low-income countries. This study had the primary outcome of all-cause mortality at 30 days. You see that glucocorticoids lower mortality compared to the standard of care with no significant differences in the subgroup analysis. I would like to make a pause here just to remind you. This is different than the other ones. It was in the non-ICU setting. Second, the utilization of corticosteroids here is prednisolone for 10 days, different than the hydrocortisone that I mentioned earlier, or the hydrocortisone plus fluorocortisone if the patients were on septic shock. These patients were not on shock or respiratory failure, not requiring ICU level of care. But even in this standard of non-ICU care, the mortality is between 23% and 26%, much higher than initially seen among all these randomized controlled trials that I showed you earlier, even in a severe group of patients with community-acquired pneumonia, but suggesting that the healthcare systems in Kenya may not be completely translated to other healthcare systems around the world, around Europe, or in the United States of America. This is why I would like to warn you to pay attention to this study, but do not try to translate to the other studies that I showed you before. Now, if we do not include this randomized control trial, as it was not in patients with severe community-acquired pneumonia, and we place it in the context of patients with systemic corticosteroids in the setting of severe community-acquired pneumonia, can the systematic review still show the same effect with the inclusion of the REMAP cap that show the possibility of harm? And in here, this systematic review was published almost the following weeks after the REMAP cap was published, including some of the authors in the REMAP cap. In here, we can see that in a less severe community-acquired pneumonia population, the benefit, the diamond, is exactly in the unit, suggesting that there is no benefit whatsoever of the utilization of systemic corticosteroids. In patients with a more severe community-acquired pneumonia, there is a benefit of systemic corticosteroids with a 20% reduction, close to 20% reduction, even after including the REMAP cap that shows the box towards the right and an increased possibility of harm, but not a statistically significant difference. When we compare the utilization of systemic corticosteroids in the long term compared to the short term that I just showed you, those patients with less severe CAP had no benefit of the use of systemic corticosteroids, but patients with a more severe CAP touched the unit, and among overall group of patients were not likely to show a benefit. However, I would like to warn you that we need to be paying attention to the more severe patients with community-acquired pneumonia. And in here you can see that the study by Angus, REMAP-CAP, has shown a possible risk instead of most of the other studies that were towards the left or in close to the unit that still show a benefit of survival. So when we conclude and we combine all these outcomes in a summary statement in this systematic review, we understand that systemic corticosteroids lower short-term mortality at 30 or 60 days, but not long-term mortality at 90 or 180 days. There was a less progression to invasive mechanical ventilation, less duration of ICU stay or hospital stay, but a higher risk of hyperglycemia. So here, I would like to summarize also this evidence from a predicted benefit of the adjuvant of systemic corticosteroids in patients with community-acquired pneumonia, emphasizing that the patients that benefit the most are among those that have severe community-acquired pneumonia, but particularly those that have a high inflammatory profile, measured by the C-reactive protein that shows that when the C-reactive protein was utilized to determine the high inflammatory profile, the utilization of systemic corticosteroids show a benefit in survival with lower mortality. Now, what happens in patients with sepsis and community-acquired pneumonia? This systematic review by the Cochrane database systematic review shows that among all the studies with sepsis and community-acquired pneumonia, the diamond is in favor of systemic corticosteroids with almost 32% reduction of death among those patients that have the sepsis and severe community-acquired pneumonia, emphasizing the improvement on short-term mortality in patients with these two conditions. Now, we have to select one corticosteroid. It looks like the majority of evidence suggests that hydrocortisone versus placebo, the biggest impact on the benefit on mortality, especially if it is a lower dose, and the cumulative probability is seen in this figure C that shows that compared to the other corticosteroids, the evidence suggests that hydrocortisone is the ideal medication for this intervention. When we look at the different subgroups, patients with community-acquired pneumonia that has septic shock, the benefit is a combination of hydrocortisone plus fluorocortisone. The initiation is as early as possible, benefiting of less than 72 hours of the administration of systemic corticosteroids. The duration is usually around 7 days among those that remain on invasive mechanical ventilation or remain in respiratory failure requiring invasive mechanical ventilation or vasopressors and septic shock. And the dosing is usually a low dose, less than 400 milligrams a day, or the dose utilized in sepsis that is usually 200 milligrams a day, 50 milligrams of hydrocortisone Q6 hours. So in conclusion, if we're going to utilize one corticosteroid, it's usually hydrocortisone equivalent low dose, started early, and the duration is usually around 7 days or more. Now, what is the caveat here? Is the possible adverse events. And the adverse events that have been identified in the literature consistently report a higher rate of severe hyperglycemia. No evidence of neuromuscular weakness, GI bleed, or superinfections, even among those that has ARDS in COVID-19 or those that has severe COVID-19 from randomized controlled trial on patients hospitalized with community-acquired pneumonia. In addition, there is a higher risk of hypernatremia, but no difference in muscle weakness as recommended before, and no differences on superinfections. Therefore, the utilization of systemic corticosteroids have shown an increased rate of hyperglycemia. Now, the other adverse events occurred in a subpopulation of patients with community-acquired pneumonia due to influenza virus. So this is a systematic review of observational studies that showed that patients that receive corticosteroids, patients that do not receive corticosteroids had an improved survival. Therefore, systemic corticosteroids have been shown to increase mortality. And this is why it's very important not to use systemic corticosteroids in the setting of influenza, at least based on the data that we currently have. Now, to conclude, even in patients that are with many other conditions, presenting on similar conditions in the differential diagnosis of community-acquired pneumonia, such as exacerbation of interstitial lung diseases, acute interstitial pneumonia, diffuse alveolar hemorrhage, acute eosinophilic lung disease, organizing pneumonia, pulmonary vasculitis, cryptogenic organizing pneumonia, acute exacerbations of COPD or asthma. These patients are considered usually corticosteroid responsive, and there is enough evidence to support that these patients should be treated with corticosteroids. However, after I show you all these randomized controlled trials that we do not have for most of these conditions, we still have a hesitancy of the utilization of systemic corticosteroids. Remember that this is a medication that is almost being used and in use for 100 years. Therefore, this is not a medication that we are going to continue forever in these patients. It will be utilized in the acute setting for patients that may have this severe disease. And this is why the guidelines recommend that in patients that have a non-severe disease with mild to moderate community-acquired pneumonia, patients that have severe influenza pneumonia CAP, severe aspiration CAP, or severe post-obstructive pneumonia, or patients that have been excluded, such as those with bronchospasm, with exacerbations of COPD or asthma, those patients are all excluded from these studies, should not receive systemic corticosteroids, even in the setting of community-acquired pneumonia. Severe community-acquired pneumonia patients, such as those with COVID-19, requiring invasive mechanical ventilation or high levels of oxygen, or septic shock, or patients with severe community-acquired pneumonia, should benefit of the use of corticosteroids, especially if you identify those with a high inflammation phenotype, measured by most of these studies with a high C-reactive protein. And this is why the new clinical practice guidelines by the American Thoracic Society suggest that in patients with non-severe community-acquired pneumonia, is not recommended the administration of systemic corticosteroids, but it's suggested that it should be utilized in patients with severe community-acquired pneumonia once you have excluded those patients with influenza viral infections. Even among those that are still not convinced that you still feel comfortable with a mortality rate around 20 to 30%, I highly recommend you to decide to utilize systemic corticosteroids if it is your mom, but not if it is your mother-in-law, except if it is my mother-in-law. With this, I would like to conclude that in patients with severe community-acquired pneumonia that presents with septic shock and patients with ARDS, there's still a high risk of death. And this is why it is suggested that corticosteroids may improve the outcomes and the mortality, particularly short-term mortality in these severely ill patients, but not with influenza. It is not clear yet which one of all is the best medication, although so far the data suggests that hydrocortisone may be the ideal medication. Second, that the dosing is usually on a low dose, less than 400 or less than 200, and that the initiation should happen early, particularly among those that are between the first 20 to 48-hour window, although the suggested systematic reviews suggest less than 72 hours. I would like to conclude with the sentence by Roe Bennett saying, "Turn your obstacles into opportunities and your problems into possibilities." Thank you very much for your attention.